behavior public health scientist, and she has advanced training in dissemination and implementation science. Dr. Lanzi founded in 2023 the Inclusive Wellbeing Translational Science Collaborative, which focuses on advancing innovative partnerships, community engaged science, and knowledge translation to bridge the gap from research to practice and policy. She's the National Director of Community Engagement and Translational Sciences for the National Center on Health, Physical Activity, and Disability. She's the Core Director of Community Engagement at the Center for Engagement and Disability Health and Rehabilitation Services. And she's MPI of the NIH UAB CFAR EHE Implementation Science Consultation Hub, which I've had the pleasure of sitting in on some of those calls with her. And she's the Associate Director of Implementation and Community Sciences Core for the UAB Center for AIDS Research. So thank you so much, Dr. Lanzi, for joining us, and we'll let you get started, and then I'll introduce our second speaker afterwards.
And just before you get started, for everyone, this meeting is being recorded.
Let's see, make sure I'm sharing the correct way. Thank you very much for that far too long introduction. So honored to be here and asked to present, and I will do my best to stay under time, and I'm looking for the share slideshow, play from start. Okay, great. So thank you for inviting me. I'm really honored to be here, and really think that I'll probably learn more from the collective than I am to share out. And as I'll say, well, actually, I wanted to say here, I sort of changed the title to say Engaged Community Partnerships, Leading Implementation Science, and looking at some strategies and outcomes, so that the emphasis is on the engaged community partnerships and how that can lead. Oh, can you hear me?
Yes.
Oh, sorry. And how that can really help guide our strategies and ultimately what happens and the outcomes. And so I want to give a brief overview of what I will share today. So obviously a welcome here, and I would invite us to do a moment of silence in just a second. And then I wanted to give kudos to our hub, and then share a little bit of what we learned from the second annual national meeting. We're just coming back from the third annual, but we had the good fortune of hosting that second annual. And then some examples of engaged community partnerships and thoughts along the way. I do invite discussion throughout. And so if you'll, if we could just start by having a moment of silence. A very dear colleague and friend of ours, Eddie Jackson, passed away during the pandemic, and we would want to honor him and all who have passed away. So if you will honor. Thank you for that. I'm just, as somebody who also sort of practices mindfulness and all kind of strategies that I've gotten into over the pandemic, I will be sharing with you some of the collective work that we've done with Eddie, and I'm just thrilled to be able to share that with you. And George, who I can see, who is joining in person, will invite him to share as well. Before we get to that, I wanted to recognize and appreciate all of the MPIs, both Michael Mugavero and Larry Harold, and then all of our wonderful colleagues and collaborators here at our CFAR, as most of the, with the Implementation Science Consultation Hub. And I'm sure most of you know what we do with these and the purpose of these, but just very quickly, we're focused on consultation largely, and around a number of areas. For us, we do most of our consultations around, of course, theories, models, and frameworks, and strategies and outcomes. I think one of the things that hasn't gotten quite as much attention as growing is this de-implementation, as well as the dissemination. And so how can we really look at what is working, what's not working, and what to do about it? And where I sit always is this engaged community stakeholder place throughout. And so hope to share with you a little bit about that. I think that all of our hubs really try to work and collaborate and consult with the grantees that were assigned to support them in their implementation science work. But I would say throughout, we're looking at ways, how can we really have community-led work that we do? And so some of this is examples of what we're doing in those arenas. But what I'd like to share more of right now is a really interesting, I think, opportunity that was presented when we were planning the second annual national meeting for the EHE supplement awards. And this was titled Meeting for Research and Community Collaborations towards Ending the HIV Epidemic in the US. And the slides will be shared, and you can see the fine print, and it's on the website. But I wanted to make the point here and to kind of set the stage for what I'm going to share with you next in terms of um, community engaged implementation science. So it's not just like community engagement over there and implementation science here, but how are they working along the way throughout? And so what was, I think, a really cool and unique thing that we did, that we started off with our, the agenda was, it was really for everyone who was present their, for their supplements, what are they seeing as best practices and lessons learned? Because as we know, this was from the pandemic, and always at the top of the pandemic was the issue of the pandemic. So really trying to get to the place of, okay, now what are the lessons learned? How can we talk about the best practices so that then we can, as you can see at the top here, apply these relevant findings to our own projects. And so for all of us, I'm hoping that we can kind of think of it in that way, learning together, the sort of co-learning, co-creation, and then planning what's next. And they were, in terms of what the different areas, it was around community-based outreach strategies, and then taking the clinic to the community, strategies to improve clinical care, and exploring intersectional vulnerabilities and structural determinants of health. And so it was really lovely to, across those different thematic areas, to see each of the presenters share what were their best practices and lessons learned, and what were their relevant findings, and how could we then, plan what's next for us. And so we had those individual presentations, and then we had breakout groups and lots of great note takers. And what I'm going to share next, and we are hoping to publish this soon, but with the collective, what we did was go back and do an analysis of what everyone shared of what their implementation science methods that they implemented and used. And so looking at that in the far left column, and in the middle, again, moving to sort of solutions for those challenges. And then overarching, what can we see as the best practices? And as you might imagine, the whole list here of different implementation science methods. And then, rapid qual, usability testing, surveys for, to assess feasibility, acceptability, how engaged they were, looking at the data sources, and trying to leverage administrative data. And then in terms of the challenges, how could we align solutions to those? So organizations competing priorities, were there ways, that they offered for solutions for the incentives, and looking at some of these available resources and innovating. Of course, the limitations presented by COVID-19 for in-person, but there was this whole new wonderful new way of engaging. And as someone also who studies a lot around disabilities, so beyond the scope of HIV, also disabilities and mental well-being, this was, I think, it's an interesting dynamic that we're seeing with COVID-19 and then post, if we can call it that, pandemic, is the engagement of those who are less mobile, and whether it's due to physical mobility or neurodiversity in terms of how they might be able to engage, uh, whether it's visuals, hearing. So being able to be in settings in which user design, universal design was present. So I think there's lots of solutions that have come up that ultimately we are able to take some from that to put in this best practices column. And always the CMEs are a good thing. And how we might be able to conduct new and directed trainings and different ways of providing materials. And so as you can see on this far right column, sort of big picture summaries of starting early when engaging community-based partners in these initiatives. And so for me, it's really, okay, we're going to start early when we start early, but then that should not be a start, stop of engaging, but a continual engaging. And what does it look like for those handoffs too? If it's sort of, we've grown to this place and now we're growing in a new sort of level of co-creation and collaborating, but always being flexible with our engagement strategies so that they are aligning with those in which we are engaging with. A true staple is being consistent and clear with your communications. Everyone values transparency, so that you're not guessing. It really speaks to trust, that is critically important, particularly when we're in any situation, and health equity and health research, by and large, always. And letting the data do the talking. So let the sort of what the data is telling us to design the implementation strategies, and not, so following this wonderful process that we've all been learning about, and having that again, how are we going to sustain the engagement and looking at these power differentials, and ensuring that the voice of the community is always right at the top. And how, again, health equity, really important. I think I could talk on this slide for like the entire time. Maybe I should have just had this slide, because I feel like obviously it was such a great grouping of supplements to share all of their best practices. But allowing the next point here, when designing implementation strategies, allowing time for iteration in the design and testing phases, so that we're not just running to the next, and having that organic nature that is important, and also those who represent various stakeholders, so that we're not just getting one lens of a stakeholder or perspective or experience. And even thinking about like the social ecological model, and how there's different perspectives to be had from all of the different layers there, and how it can be that bidirectional nature to it. And to that point, the health messenger being critically important. So having people with lived experiences, again, in all of the arenas, as I was stating earlier, about building trust and authenticity to the work that we're doing. And always, of course, funding is the best practice. So ensuring that you can have from the beginning, the end, right? So that there isn't an end. And how are we gonna aim and get to there? How are we going on time, just so I can gauge?
Yeah, you have about 12.
Okay, good, because I only have 86 more slides, so we're good. But before we get into this, actually, I think, I don't know if can be interactive or not, but if so, feel free to put into the chat some considerations that you would like to share. I always love this to be sort of a co-created set of considerations. So please put into the chat if you like, and I invite um, our DC CFAR colleagues to share some of their best practices as well. But I think that assembling teams and partnerships really shouldn't be an and, it should be just our partnership teams. It's probably how I would rewrite that slide there. But that it's critically important, as I've been stating, how you show up, who shows up, and how you show up is important, and that consistency. And I think taking into consideration all ways that people can show up, so that if there are some who might need some closed captioning, which is so lovely that we have that here, or who may have neurodiversity needs or may need to have some food allergies if there's food being served. Certainly when we have our partnerships, it's not just to get something out of them, but ensuring that when they come, they can fully participate. And depending on the focus of that moment, whether it's in that time period, whether it's kind of talking about what the plans would be and how that might be a good time to go beyond just doing focus groups and interviews, which are lovely, of course, but there are other so much more fun ways of working together, whether they're like conversation cafes or different kind of community engagement studios and lots of different ways to work together and get information from them, from us too. Like, what can you do for me? Like, what are you doing that you might be able to help me with? I have this general thing that we want to do something about, but I don't even know what to ask for. A lot of the times is what I see. So I think that the team's a very big consideration is that team, if at all possible, is equally like at least, you know, not just one person from the community or not just one person from the academic arena, because you're really just measuring it N of one of what that represents. And so really we want to look at the different facets of what we might need from different stakeholders and incorporating them truly into the whether it's the formation, the implementation, evaluation, or de-implementation, and then dissemination, and our wonderful circle that we go through with that. So I just, again, want to honor Eddie Jackson, who at our CFAR worked with him for many years. He was our community engagement programs manager. And we were very fortunate. And this is when I met George Kerr at the DC CFAR when we were up at Rochester for the first Faith and Spirituality Research Network. And we were just launching ours, and we were all in. So we just started doing all of these. Hopefully this shows up. I, for some reason, thought it was fun to make it blurred on the side, but it probably just makes it really hard to see. But this, you know, if I had blown this up to a regular page, you would see how many people just started coming to these HIV and faith and spirituality, really just more networking opportunities, but also having faith leaders come for our town hall, and then with the Black church and HIV, the coming over from Georgia and other, you know, across the country, doing these community forums. And so it was really helping build this collaborative. And it couldn't just be, okay, we want to do research, we got to, you know, find out. It was really learning, listening, and somehow we were able to have this really lovely early on, again, a really co-created opportunity to just discuss ideas and opportunities in new directions, and bringing together researchers and the community. And so really fortunate to have Reverend Edwin Sanders, Christopher Hamlin, Pam Payne Foster, and Amy Nunn is our panel members and everyone in the community there. So here's just a number, but I really want to kind of get forward. This was one of those first ever in Alabama where we had trainings across the state with the AME Church clergy on HIV training, and had, for their 5 conferences across the state, it was a true partnership with the church, actually saying, because we had already this partnership, and then it became present in the AME Church that they needed to have these HIV trainings. They knew who they wanted to come to, and co-designed it with the Head, Heart, Feet model. And it was just lovely. And they named it the Love with No Exceptions. And isn't that, well, you're in the South, so you got to have some food and good food there all around. So they were so lovely with all the food. The bishop came, and so had all of these really amazing partnerships, and lots that we were learning, just even differences between clergy and laity, and what they're reporting and what they were sharing that the faith community was saying that needs to be done to address, and what we might need. Here, I just wanted to give a few highlights on ways that, and this, George, I really invite you to share, but how we really shifted with our sort of new directions during a pandemic. For, at the time, our core was the Behavioral and Community Sciences core, but started, of course, doing lots of social media, virtual offerings and research, and having this very detailed, specific strategic plan that was co-created with our community partners, and what they thought it should look like, and what they wanted engaged, and all the different platforms, and how we could tag our organizations, influencers as they wished, of course, and hashtags that they were using, and across these different platforms. Of course, there's different things that you should share. So shifting to, we started during the summer of 2020, as we all know what was happening then, having these amazing, really not funded, unfunded, I guess, seminars with amazing people across the country, and really, so as you can see here, the main topics here: how lessons from HIV are informing the COVID-19 response, innovative approaches to community-engaged HIV research and ethics, how HIV is informing COVID-19 vaccine research, harm reduction in HIV community, faith, HIV, and mental health during COVID-19, and who doesn't want to celebrate? So I'll just sort of click through these, and you can see all the wonderful broad participation too that we had. And George Kerr here, faith and healing, harm reduction in HIV community. George, would you mind sharing? I don't know if you are close enough to be able to share. If not, I understand. But any sort of key tips, pro tips that you want to share?
So I would just interject quickly that it involves involving the researchers and the community, and bringing the community in the beginning when you're having these discussions, because you will find that you will hear things that you wouldn't necessarily hear. And that's the role of the community, is to let you know what's really out there. And so this was a very powerful session that we had on harm reduction and healing. And right now, harm reduction is like the new key word right now in research, and we need to do more. But I would just say making sure that you have an equal balance of researchers and community participation.
Yes. And as you said, from the beginning throughout, and truly, partnering, not just checking a box or just indicating that you're there. And this one here, I can't even see what it says from the link here. I should recall, but we had great community engagement here from across the board. Always the next one was our celebration, I believe. Yes. Celebrating the role of faith and spirituality in HIV prevention, research, and treatment. And again, Elder George Kerr helping bring the panel together. And I just have to give a huge shout out to Elder George and Eddie Jackson and Jimmy Gibbs, who was there, as well as Delora throughout. And I am trying to see how many more are shown here. And Lewis Shackelford was kind of our core group. All gave, of course, of their time, and Pamela Payne Foster and them really started. And so it's lovely to have so many people from many different facets participating and sharing. I don't think that I'm going to have time to go through this, but it will be in the slides, but how engaging community health advisors in HIV, Hep C infection, and colorectal cancer screening and treatment navigation efforts. So that's something happening, and how that can help inform the HIV, so hepatitis C and colorectal cancer screening in with HIV, because at that point it had not been done. And so really we done sort of these 3 and then ultimately 4 waves of going through that. And as you can imagine, engagement, education, and stigma were really central themes that we were hearing. I think I saw Jenny Wise here, who also helped, or no, that was Jessica. So it's nice to see you, Jessica. And this was really a fun one. It was SBIR on sexually active adolescent focused education, where we developed a mobile-based game to help teens think about their sexual health decisions. And this was really cool, different ways. I could share more about that as well, and how it was because of what the youth told us they wanted, not because of what we thought. So I will stop there because I'm imagining I am about out of time. But I'm happy to keep talking for sure.
You just up perfectly.
Perfect time.
So maybe we can see if there are any questions from the audience.
Yeah, so we had 2 quick questions that we'll take, and then we'll move to our second presenter, Ade, and then we'll open up at the end for more questions. But we had 2 questions from Paul Gase from the NIH Office of AIDS Research. And one question was really focused on how does disinformation or malinformation, how is that taken into consideration in your research and practice? Is it tangential, or is it a central focus of your implementation science work? And then the second question was, that some of your sessions might have been virtual and in person, and whether you had numbers on participants and or outcomes.
Yes, thanks, Paul, for your great.
Hold on. Paul, was that question for us as the CFAR, or was that question for Robin as well?
That was a great point you just made. Maybe for everybody, for all of us. Thank you so much for reading that. Thank you.
Do you want to go first, or would you like me?
No, go ahead, Robin.
Well, and thank you, Paul, for just being so kind. Yes, I will say too, as a developmental psychologist who is very dedicated to mental well-being, and all of the work that I do, whether it's more broadly in disability and chronic health conditions, or obviously in directly in HIV, the disinformation, malinformation is just as important, and sometimes can be even more so important, as it can have such a downstream effect, and not just like a one downstream effect, but it can be just a snowballing and continuous factor. And so you have to, though, just as much as you are documenting, as we all do, the barriers and the facilitators, but it's the and what. So like, what are you going to do with it? How are you going to do that? And having those SOPs or MOPs in place so that it's clear to all, and having good training at the beginning and continuous training, because so many things come up that are not anticipated. And so I've learned, unfortunately, along the way, when you don't think certain things will happen and they do, even from within, and how you have to have even agreements within on how to report things, and what is the action plan if things happen. And so just having a lot of scientific integrity. I say this because I again think of things in sort of the social ecological model, and so your questions really could relate to, I think, all levels, and how in your manual procedures or SOP are you indicating that these are the procedures we follow, this is how it will be taken into account. And that is one procedural. And then the next is research wise. And so saying, if, we get to X and we find out this is how we might, calls for review, and then to consider de-implementation. Policies, of course, the same way. If we have policies in place that are not serving in the way that they should, we need to do something about that. And a lot of times I see policies in place, but not good practice. And I think advocacy skills are one, and self-advocacy are ones that really need to align with the work that we do, so that our community partners are having those kind of toolbox in their pockets, so that they can also advocate for themselves and have the resources and know where to go and who to go to and how and when, and know that they can count on you to go with them to do that as well, or who on your team is a touch person for that. So that's how I would answer that question. Is that what you were?
You. Thank you very much. And also your emphasis about building trust and relationships is so key and central, that when there is these strategic, sophisticated, the disinformation and malinformation campaigns that can undermine your effort and the goals we're all trying to achieve, that trust and that relationship is really what's going to get you through. But it's harder to say, and what are the tools to prevent and or mitigate the disinformation, malinformation impact? And that's something that is always swirling around my head, and I wish we had better answers at this point.
Well, I appreciate your point, and it's good that it's still swirling around, because I don't think that it's ever going to settle and go away, because new problems keep coming up. I do think, though, that we need to continue to have our stakeholders co-create those procedures and solutions and action steps, and even sort of a mentored approach to developing the mechanisms and strategies, so that they will continue to follow along, and you can continue to build that foundation of trust and transparency.
Excellent. Thank you so much.
Thanks for that, Paul
Yeah.
and Robin. And, Paul, one of the key pieces for me as a community member with dis and malinformation, I do a lot of work in equity. And I think today there's also a lot of disinformation and malinformation related to equity. We benefit from having access to quickly produced relevant research on how to address that in different parts of the country through the Frameworks Institute. And I encourage, as through implementation science, as you're identifying strategies to address it and combat, developing those tools to disseminate to the community really quickly, so that the community could utilize those strategies as well, is really helpful. So I just want to thank you so much, Robin, for that. Those pieces around trust building, so critical. And we're going to transition over to Ade, and then we'll open up. So if you have other questions for Robin, please put them in the chat and we'll ask them at the end of the presentation. So thanks so much for that.
Thank you.
And Amanda will introduce as she's pulling it up.
Thank you again, Dr. Lanzi. So our next speaker is a local DC CFAR supplement awardee. I'm just going to call you Dr. Ade, because otherwise I'm going to mess up your last name. Ogunbajo. Dr. Ade Ogunbajo. Did I say it well? Okay. He is the Director of Research at Us Helping Us, People into Living Incorporated, which is an experienced community-based organization with 2 locations in the greater Washington, DC area that offers HIV primary care, PrEP prescriptions, case management, and many other services. Dr. Ogunbajo holds a PhD in Behavioral and Social Health Sciences from Brown University and an MPH in Behavioral Sciences from Yale University. His research interests are on issues related to health disparities and inequity, specifically HIV prevention and treatment, mental health, and substance use in racial and sexual minority communities, both in the United States and across the African continent. He is interested in the determinants of health outcomes among African immigrant communities in the US. And when he's not working, he enjoys baked goods and television.
You got your whole bio.
Well, Dr.
Thanks for the
Ade, will you,
Thanks
thank you
the
for being here.
introduction.
Look forward to your presentation.
Yeah, thanks. I didn't think you would share that last part. I think I added that last part to sort of be like relatable, but I think I might have removed that from my bio.
Do
A friend
not remove
actually,
that. Do
I
not
think-
remove that. Do
I
not
think
remove
it went out
Yeah.
in the announcement, and a friend like sent me like a screenshot of that part, and they were like, "You don't really enjoy." I mean, I do, but anyways, let me share my presentation. Thanks for the introduction.
Well, we enjoy consuming baked goods, so if you like me.
Baked goods, I definitely enjoy. But thank you all so much for the opportunity to talk about our EHE funded project. So how I'll sort of structure this is I will sort of speed through and give an overview of the project and then kind of focus in on 2 things. One, the implementation science framework that we've decided to sort of employ for the project. And then second, I'll talk about our sort of community engagement approach and what's been working, what hasn't been working, and how we're really thinking about community engagement as it relates to this project. So the title of the project is really looking to develop and pilot test interventions to improve care outcomes for recently incarcerated folks living with HIV in the DC metro area. And so we know that within the United States, there exists racial disparities in prison incarcerations. And so there is an overrepresentation of people of color, but specifically Black folks in the United States, where we see here the total incarceration rate across the United States and Black folks being just disproportionately represented within the criminal justice system. We know this is rooted in racist foundations and rated in the current criminal justice system and the prison industrial complex. Additionally, we know that folks living with HIV, while there's been a decrease in the number of folks living with HIV within the criminal justice system, so that includes state and federal prisons. We also know that there is currently much higher prevalence rates of HIV among folks who are incarcerated compared to just the general population. And the literature has found that when looking at HIV care outcomes before, during, and after incarceration, they found that once folks are released, they have a decline in linkage to HIV care, as well as are less likely to be retained in care, and also which has implications for their viral load suppression, as we all know, the HIV care continuum outcomes. And so this really was the precipice for our project, because in DC, we know that Black folks are overly represented within the criminal justice system, so specifically in jails. And we have this graphic showing so the percentage of residents compared to the percentages of folks in jail, and about 90% of folks who are currently incarcerated in DC are Black, even though they only make up 44% of the general population. Additionally, we know that DC has a high HIV burden, and so we see that when looking at lifetime risk for HIV acquisition. In DC, it's about 1 in 17, which is much higher, about 10 times higher than the national rate, which is about 1 in 106. So these two things are sort of juxtaposed where, and I guess I should also mention that there's also a burden of HIV among the Black community in the Washington, D.C. metropolitan area. And so these things are sort of, as we all know, interlinked. But we also don't have a lot of evidence on evidence-based interventions to improve HIV care outcomes among people living with HIV who have a history of incarceration, especially in the DC metropolitan area. And that was sort of the precipice for our proposed project. There was also an emphasis for this particular population in the last EHE funding. And so we decided to put something forward. And so we really came down after having a liaison with some other partners, we proposed the following research aims. The first sort of kind of a traditional research study where we're first really identifying the barriers to engagement in care and thinking through potential interventions for this particular population. We did do sort of two things differently. The first was that we sort of provided an array of the kinds of services that folks might be missing or might want to be engaged with that they currently don't have. So outside of just medical care, which is what a lot of folks tend to focus on, we really were trying to look at sort of comprehensively the different needs that folks might have. So economic stability, psychosocial health services, and holistic needs. And we also, rather than just talking with folks who we are trying to intervene on, we decided to also interview people who work with these folks. So case managers and healthcare providers, peer support workers, folks like that, who can also give a different perspective where they're echoing some of the sentiments, as well as raising additional issues or ways that we can intervene that the clients may not even be aware of. And then the second aim is to really just pilot, once we get the feedback or information on what's needed, really pilot in an intervention and seeing how that moves the needle when it comes to HIV care outcomes. And we, in sort of thinking about all of this, we sort of dug through a lot of the different implementation science frameworks and conceptual sort of models, and it landed on the health equity implementation framework, which really centers the clinical encounter of the patient. So that's the ultimate outcome that we're trying to, that this is sort of focused on changing. And so in trying to do that, it zooms out to look at sort of the different patient factors that influence that encounter. It also looks at the provider factors that influences that the provider factors that influences that encounter. And then sort of within that relationship, it's sort of, it's located within sort of the organization level factors, the health system factors, local level factors. So some might sort of think about the socio-ecological framework as sort of this being a sort of taken from some of that. But with this, it's really focused on the clinical encounter, because ultimately we know the clinical encounter with this population, or just in general with HIV, really does influence the care outcomes and whether or not folks stay engaged in care. So yeah, it's sort of we thought this was a good framework, and we really utilized it to guide our approach to how we're asking questions, and as well as we hope that it will also help with our data analysis once we have a lot of data. So these are the inclusion criteria, which we've had to tweak a few of them because it's a bit sort of stringent. So you have to be 18 years or older. The identification, we've actually kind of, because when we really sat down and looked, these are more priority categories than sort of rigid. And so it kind of includes everyone most folks who are sort of bear a heavy burden of HIV within the DC metro area. And so at this point, we're really only focused on the age, you having a history of incarceration in the last 24 months. It used to be 18 months, but we sort of made that sort of a bit longer to be able to catch more folks. And then also having HIV diagnoses. And DC metro area, we've also had to sort of expand that to Prince George's County, Montgomery County, and Northern Virginia as well. So in thinking about community engagement, for us, it's a little bit different given that we are a community-based organization. And so, but we also didn't think that made it such that we good at doing community engagement and not needing to really engage with it, especially because we don't necessarily work directly in space as far as working with folks who are incarcerated and sort of doing sort of re-entry services. So we really had to think really critically about how we want to engage with other community-based organizations as a community-based organization, and what are the tenets for that engagement. So that was one. So what we did was, in thinking about our recruitment strategies, we did sort of glean on in-house clients and different programs. So we do have folks who meet the inclusion criteria that we were looking for, and we sort of started there. We're trying to think about how to talk about the program with them, or the research project with them. Usually we started at the case manager level because a lot of those folks are in case management, just given the complexities of their lived experiences. And so the case managers were sort of the middle people to sort of present the research project to them and sort of see if they would be interested in participating. We also have some programs specifically within the harm reduction space, which was talked about earlier, but we also know that some of those clients in the harm reduction programs meet criteria for the studies that we're trying to implement. And so again, we utilize our team members who work directly with harm reduction to present the research project to potential participants and get buy-in at that point. We also have research-specific outreach efforts that we do. This hasn't worked as well, just given a large swath of our portfolio is with sexual minority men. And so if you think about where we are doing recruitment out in the community, usually the folks we're looking for are usually there. It's hard to sort of say, hey, we're doing a study on folks who have been recently incarcerated and are living with HIV. Are you interested? Because that can sort of, I don't know how that conversation is not really a conversation that you can kind of have with someone. And it also has some preconceived notions around why would you approach someone and sort of have that be the selling point. And so this hasn't really worked a lot, but we do ask very general questions as part of our intake process for our outreach. And then we see if there are folks who say they're living with HIV, we might reach out to them and say, hey, we have this research project. There's another component around incarceration. And if that's not your situation, then it's fine. But we also present it to them in that way as well. I guess the biggest way that we have sort of fostered intentional collaborations was actually working with a community-based organization, Voices for a Second Chance, in the sort of development of the protocol of the proposal in that stage, because the funding announcement actually kind of required that as far as having this sort of collaborative partnership with organizations that work with the population. And so we had several calls us and seeing if they were interested in a research project or us working collaboratively and sort of iterated on the research questions, the approach and things like that. And then but then also made it clear that there's no funding guarantee. And so if this doesn't go through, that we're clear on it being a great project, but we obviously can self-fund. And then once we actually got the letter of the funding announcement, we then put together a mutual understanding form where we clearly outlined expectations, shared goals and objectives, and we signed. And then now in actually sort of implementing or working through this relationship, we've had to be flexible in just how we're working with them, processes, just given. So they're helping us sort of talk to their clients that they provide services to about the research study. And so we're working a lot with their program managers and they're sort of doing the handoff. And so that might mean us having to go to their offices and have the conversation with their clients, or actually having the interviews in their office space, or doing maybe virtual interviews versus in person. So we've had to be flexible, just given the lived experiences of the clients. And then also one thing that we really prided ourselves on was being very transparent with the budgets. It's a small supplement grant. It's not a huge study, but we also wanted to make sure that we were providing financial compensation that was commensurate with the expectations that we were setting forward. So that included just we made sure we had like a payment in place for them just being a part of the project, as well as also incentivized each person that was successfully recruited to be a part of the project, just to sort of make sure that we're not, that we're being equitable with the funds that we do have. And the last point I have here is a work in progress. I should also mention our office space also happens to be co-located with a reading program for folks who have been recently incarcerated, which sort of was by chance. And so they're called Free Minds. And so we've been in conversations with them around some, if you might be able to talk to some of their team members and interviewing them around their work with this community. And that's an ongoing collaboration that we're trying to build. And again, this came from us going in our office space and sort of learning about, like you all, what work do you all do, and conversations, and finding out they actually work with this population, and then going from there. So the last point I was going to make was, it is a work in progress. We were hesitant, I will say, I was hesitant around this proposal, just given how specific the target population was. And even in the consultations, there was enthusiastic, realistic enthusiasm around the project, around there having been difficulties in the past with recruiting this population. So we're sort of learning as we go, but hoping that we really are able to successfully recruit and really learn. And we've had, quite a number of interviews so far. Sorry, was there?
Someone was just unmuted, but if you could also wrap up in the next couple of minutes, that would be great.
Yeah, I have one more slide. We've made quite a bit of progress, and we've actually started to, I'll actually move on to my last slide. We've started to do some preliminary, so we're still recruiting, and I'm in phase 1 with the interviews with the clients as well. And we started doing some preliminary analysis interviews, and we're really excited about the things that, well, maybe excitement isn't the word, but a lot of the information we're gathering is very illuminating around how we can design the intervention. And we are hopeful that this will be something that really gets us to think outside of the box about the needs of this community, and how we can try to have them not fall by the wayside, given how complex their life experiences might be. So I will stop there. I believe, I have my email address here, and we'll sort of leave room for a conversation at this point. Thank you all.
Thank you.
Thank you. All right, so want to open up, and if we could pull up the chat so we could see any questions that you might have for either of our presenters. Go for it, Paul.
Sorry about hitting all the buttons back and forth. Thank you, Dr. Ogunbajo. Thank you so much. First, a quick commentary, and then I'll get to my question. I always like to compliment when I see, and I saw it in your framework slide, where you have economies. Too often I see folks say economics. And I think it's really, just want to highlight about how important, especially when we're talking about determinants and social determinants, that economies and the systems that are those economies are important. So thank you for that. And what you're doing is a very important work. A quick question, it seems like your focus, and I'm sorry if I'm slow to the party here, the focus is on the release, essentially that bridging when someone who's incarcerated is released from incarceration and their transition back into their community or wherever it is they go in terms of their HIV care. Is that correct?
Yes, it is, exactly.
Okay. So again, I want to emphasize important work that you're doing. My question is a little one-off, but I want to pull on all of your expertise. In other rooms that I work in, I work with other agencies such as HRSA with Ryan White, and it makes me think about that bridging element and whether or not, independent of what you're specifically working on with the CBOs, et cetera, just intellectually and maybe practically, do you think that one thing to explore might be looking at where it's appropriate prior to release of creating that bridge where it's feasible and logistics work, Ryan White programming, so that when the person is released, they're already set up to be moving into the Ryan White Center that's near them or whatever, and they're a known entity and that bridge has already happened. Because that's an established infrastructure, and maybe that's just a whole answer is sitting there waiting to be seen. And asking your thoughts about that.
I don't want to assume that that's not happening currently. I know municipalities and prison system and jail systems are very individual in their approaches to case management post release. I know there's incentives to make sure that that recidivism is low. So I don't want to assume that that's not happening. I've been actively listening to the interviews, and there was a particular participant that mentioned being released and then having to navigate actually finding a healthcare home. I'm not sure if they were diagnosed close to when they were incarcerated, but that process was very difficult for them. So they were connected to a clinic, but then they were refused services because they didn't have an identification that was needed. And so they were turned back, and that was a barrier. And then they had tried again. I think they had tried initially to reconnect to where they were getting services at first, but then they were late to the appointment and then they weren't seen. So it was just a lot of navigating that. And they even admitted, they were like, I should have given up. Like, I shouldn't be in services because all the things I've had to sort of navigate to get here has been unnecessary. But they still persevered. And so I think what you just mentioned seems like something that is sort of like the minimum, I would think, of just someone who's thoughtful enough to say, you're being released. We know you're someone who's living with HIV here. Like, who are you being released, or where are you going to be? And here are, a list of places you can get services where you don't have anything out of pocket. But I don't want to assume that's not happening, but we know that
I'm not even talking about that. I'm talking about an active program that is setting up that bridge. So it's not, here's a list of services, here are places you can go, that, we're seeing really important results coming out of the Ryan White program. And I agree with you. We should not assume it's not already happening. I think you may absolutely be right. But I think it's also, as from a research point of view, might be worth I'm not even saying you specifically, your plate is
Right.
quite full with everything that you're doing, is that
Yeah.
it, for all of us, it may be something to be thinking about and looking into. And so, thank you.
Well,
Can
I
I
just
just
wanted
add-
to add, oh, go ahead.
Yeah, I just want to add, I think, Ade may have been referring to me during that consultation call because I was one of those cautiously optimistic people. And I just wonder if you, after you get this data and you get this information, if reaching out to an organization like CSOSA might be a way to develop that kind of program and to try to gently nudge to get that type of a program in place so that it does become more routine. I think one of the issues, and Ade, you can speak to this more intelligently than I can, but is that DC doesn't have a prison, so it has a jail system. But if you have to serve a term, I believe longer than a year, then you are sent outside of the district. And so I do think that that complicates things in terms of re-entry because people are coming from all over, not just, it's not just that they were incarcerated in our community and coming back, but they really are re-entering the DC metro area as well, as from what I understand.
Yeah, so two pieces, Paul, in response to your question, CMS last year announced the ability for states to add to their 1115 waivers Medicaid programs where prisoners could be connected to Medicaid prior to release. So a couple of states, I think California, Washington, and maybe Montana have programs through their 1115 waiver where they have community health workers, etc., connecting with prisoners prior to release. The only reason I know that is because DC Healthcare Finance was working on their 1115 waiver to integrate, potentially, it was one of the options on the survey as they're in the process of submitting in June their new application, their revision to their 1115 waiver. And we're thinking of including that pre-release access to Medicaid as part of that 1115. So I need to review the final, but that is an option for us to work together with whoever's doing that outreach on Medicaid to ensure persons with HIV are connected to services prior to release. So it is something that CMS has allowed as of 2023, and there are opportunities for that. And I'll just add to the piece that Amanda, you just mentioned related to DC not having jails, but having prisons and working with CSOSA.
A jail, not a prison.
Sorry, a jail, not a prison. A key piece as we think about these programs, when we met with CSOSA for another training program, there are so many prisoners who are returning are just looking for jobs. So as much as you could connect to employment programs, so the first thing they're looking to do is not focus on their health. The first thing they're looking to do is figure out money. So in addition, it is that I know Voices works on that too, but it is thinking about, are there opportunities for employment as well that could be connected to your work? So yeah, but great stuff. Paul, I see your hand again.
All very important points, and part of, I don't want to give the impression that I think everything starts and stops with Ryan White. It is a national program. So if someone is located here or there or wherever, it's worth seeing what the overlay is. But it's not the only option, of course. And I just wanted to make another comment about the example, sir, that you used about the individual saying, I probably should have dropped out. There were so many barriers, this and that and the other thing. And I just want to say, it just makes me think about, well, for a person who's not incarcerated, seeking health through the healthcare system in America is not a very easy thing to do, period. So now you put that overlay, right, on top of it. And so it gets us also back beyond the work that you're doing, I understand, about larger root causes of why we are getting health outcomes or the lack thereof that we seek. In part, it can be as simple as it's just too frustrating to get, from one place to another, to get an appointment, 3 weeks within a 3-week time frame of when you need it, et cetera, et cetera. And so those are root structural issues, and then you put in inequities with that, and you put in the systems that are beyond that, acting as barriers. It's amazing anybody's in care for anything. So with that said, thank you for doing that work. It's incredibly important. And thank you also for really, bringing the community-based organizations into the roles that they really are positioned and talented to do. And look forward to hearing about your work.
Robin, you were gonna unmute just a bit ago.
Oh, I guess just as a kid who grew up as whose dad was a superintendent of a correctional facility, and a mom who was a secretary, and a different one, but that I just think about that. I mean, I'm 55, so this is quite a while ago, and just thinking, and we lived kind of in the country. So, and I think about rural Alabama now and just what it looks like here as well, and just all those determinants, and how difficult it is to really make those connections and supports, and it's just sometimes easier to just not. And how I think aligning those senses of hope are so critical at all stages, and providing those sources of support to give hope, and continuing to believe, and advocate, as we've been saying, and help them feel like they can advocate and have action. Yeah.
So I have a question for Ade. Harm reduction, you spoke of that, and right now they're really struggling with this drug-free zones and the community not trusting them. So how are you adapting to the political climate of the day here in DC with all the violence and that, and trying to recruit?
That's a hard question, George.
I know, sorry to say it.
No, it's fine. I wish I had someone on our harm reduction team here to answer that. I honestly can't. I know they have I think of any other team within the region, they have very sort of unconventional outreach. They're required, like they kind of have to reach their clients. There's a lot of unconventional outreach approaches and like meetup spots and things like that. I'm not sure of the intricacies. They are also very, very, very guarded about, like, we can't just sort of go with them to do outreach, because a lot of they know the community and they know trust is a big thing. And so I don't get a lot of sort of first-hand view of like how they do the work that they do. But I will say they've really been instrumental in getting us a lot of initial participants. And then also the one thing I forgot to mention is, or maybe two additional things. One is then those folks are then also referring, other folks who they think have really good insight. And I also should say that in our data gathering sort of, we also try to ask sort of proxy questions, because we recognize that if folks are presenting to us and we're able to actually talk to them, they're probably a bit on the more fortunate side, as far as they've maybe been connected to like services or care or some sort of helping hand. And we know that we're not really catching the folks who really are have more dire straits. And so we're asking a lot of like proxy questions around, like, think about folks who aren't here at the moment. Like, what do you think? Like, how are they sort of navigating this, or what ways do you feel you've been able to sort of navigate this or deal with this in a way where most people haven't been? And that's been really instrumental to really understanding folks who might even have even worse experiences within the healthcare system, getting services. And also around employment. Employment is a big thing. That's the first priority, is getting a job. And there's still a lot of stigma around being formerly incarcerated and having a record that folks have to sort of overcome. And it's very difficult.
Yeah. I have a question. So both for Ade and Robin, so with both of your programs, it seems like at least for the faith-based Robin, the advisory or the group of stakeholders you've engaged seem to be faith institutions. And Ade, it seems like it's the organizations that work with persons who have been incarcerated, who are sort of serving as that advisory engaged community. Do you have plans to also engage like directly persons who are recently coming out of incarceration to shape your work and the implementation science research? And likewise, Robin, persons who are in faith but who are not in the institutions per se, because I find those perspectives tend to be different.
So we're doing both. So we're talking to folks who meet the criteria, so living with HIV, recent incarceration, and then the providers who serve them, and sort of asking similar but different questions. And then ultimately the intervention will focus on folks who are living with HIV who have a history of incarceration. It's been a bit more difficult to get the, like, sort of, we call them quote unquote the clients than the providers. But we've been making a lot of headway. So we are sort of consulting both. We also made sure that the numbers that we were proposing to do was feasible and not like outlandish where it's really impossible to get those numbers. So we've been doing both, and I found the interviews with the clients probably more illuminating, and just folks are very real and tell their stories in a very visceral way. And very touching, and are really enthusiastic to participate than any other study that we've done. Yeah.
Oh, sorry, just to clarify, I know from the study perspective, definitely, but from the people who are paid to actually do or shape what comes next. Yeah, I mean, because right now it's like voices.
That's a great,
Right?
no, that's a great question. We're not there yet. Because like if there was sort of like, and I know there's like advocacy groups that are made up of folks who have been incarcerated and sort of who do advocacy around like policy change, things like that. We haven't gotten into that space yet, honestly, because our like comfort zone is sexual minority men. This is a little bit of a different space. So we're kind of we were able to sort of get connected with a community-based organization, and that's sort of been our working relationship. But we're hoping that we can sort of use this as a building block to do even more. But we want to start somewhere. But we've definitely not. Yeah, we've not. That's a blind spot, and we recognize it. But we also know we're not. This isn't really our, like, our bread and butter. And so we're trying to do things piece by piece.
Awesome, thank you.
Go ahead, Robin.
I was just gonna answer kind of how we did it with ours, and just, it was a really important, I'm glad you asked that, in case I gave the impression that we only worked with leaders as our stakeholders. But no, it was, those were just that was just an example with the AME Church, and really these partnerships and connections came from those who were in the community who said, this is what we want, and oh, let me introduce you, kind of thing. So, and I would like to also emphasize faith and spirituality, not religion, just,
Awesome.
I was hoping, I know we only have about 5 minutes left, I think. But Robin, at the beginning of your talk, you said, you gave us kind of the different aspects of implementation science in the figure, and you mentioned de-implementation. And I was wondering if you could just talk a little bit about that. That's not something that I'm very familiar with, and I think that it might be nice for the room to hear a little bit about that.
Yeah, so de-implementation, I think some get it confused with dissemination maybe, and like we're gonna stop implementing and share, disseminate out. But it's more looking at, and I think Paul was trying to get a little bit at this too, and maybe in a different kind of way, but that when we find things are not effective and we are studying them and or have policies in place that are not doing the thing well, and it's not providing, it's not doing as it should. And so we do need to have in place, when will we de-implement? When will we stop? What strategies and methods and mechanisms will be in place so that, again, it sounds like I'm a big protocol follower. Maybe Paul would like that, but that we should have in place when we know the thing's not working and the thing should go away, kind of thing, and whatever area in that equity, frameworks. So I don't know if that's a very quick answer to it, basically. There's a whole
Great
science to it too. Yes.
Yeah, awesome.
Interesting.
I just have one last question. And that was, Dr. Ogunbajo, when you were talking about what was your impetus to reach out to a community group, you talked about the fact that the funding sort of required it. And I'm just curious as to whether, I mean, it's hard to say, but how much of an influence is that funding directive on whether you would have actually engaged with partners for so much of this work, or as you see other projects being implemented, how much of that funding directing you to work with community groups, to work with community partners is critical for this work to continue in that way? That's for both of you, but.
Yeah, I like that question. I think I made that point to say, there was no way we would do this without the collaboration, just given our reach and our population of interest. There was no way we were going to be able to get it done. And I also didn't want to put my name on something where I knew I wouldn't be able to recruit and actually meet the deliverables, and just given. So that was a given, and we almost didn't submit the application because the collaboration, as we wanted it to sort of come together, was probably more last minute, and we were just going to not do it if we didn't have that buy-in. So given my background in academia and then sort of now working within research and nonprofit, I know how it works when it's sort of like write us a letter and like see you when we like, and then so I know how it works when it's not intentional. And I'm trying not to replicate that within my new role as
Awesome.
I guess community researcher is what we've been calling it. So yeah, it was a given. I mean, it also helped. I do think it helps when the funders sort of push folks to have that, because not everyone is, I mean, folks, sometimes it's like just having a letter, but when it's more intentional, and it's kind of required, it kind of then requires folks to sort of like then actually try to build relationships versus just getting a letter. But for us, we weren't going to move forward if we didn't have that collaboration. And I also don't want to paint a picture that it's been sort of like easygoing and like smooth sailing, because it hasn't been, but we also know, being a nonprofit, how things get busy and people get pulled away. And this is a one-off, like this isn't their main, like they have other things that they're doing as an organization. And so, but we keep pushing forward and we feel like we're moving in the right direction. So we were going to move forward. We weren't going to move forward if we didn't have a partner. But I think it's good when funders require that.
Awesome. Well, thank you all so much. We are right on the nose at 7. Robin, if you did want to answer that, you're welcome to as well. But just wanted to share our appreciation for you both sharing your expertise with us. Thanks to all of the attendees as well. I'm seeing some names that have been on all 4 of our series. So thank you all so much. And of course, thanks to George. George, you've been involved in this from the beginning too. And Christian for all of the logistical help in pulling this together. Amanda for your just amazing brain power and leadership. Thank you all so much for this. And this has been a phenomenal series. I learned so much. So just want to say great appreciation and Amanda.
Yeah,
Christian,
no, I
anything?
think, yeah, I have nothing to add but gratitude and keep up the good work. And thank you, Robin, for sharing your experience. It's always helpful for us to hear what other CFARs are doing in this space. And so we truly appreciate it.
Well, thank you. I appreciate it too. And Day, it's nice to see you and hear all your great work. And actually, I'll be at Hopkins next week, so maybe we'll see each other at the the meeting there with Cherie and team. So
Oh, yes, I will see you there.
What is that? Can you, I'm blurting out. What is that meeting at Hopkins?
we want you there. I'm going to send you a calendar invite or ask Cherie to.
Well, send me information. That'd be great. Yeah.
It's